Okay, so quickly we just go in through my presentation of a little difficult problem, which I hope you can all see it. So the treatment of thrombus containing lesions is a big problem, and about 24% of our patients in the STEMI program, which we ran in Tamil Nadu, had young MI, and many of them had large thrombus, and many of them create issues which would land up with complications on the table. Many of them are plaque erosions, and I'll tell you how we deal with these things in large thrombus, how we manage these patients. So we have various classifications, but clearly we are talking about the grade 4 and 5 thrombus, which are large dimension thrombus, which occupy most of the lumen. And if you look at thrombus, you have to very clearly know that what is, apart from the amount, it is the fresh thrombus, which is less than 1 day, lytic thrombus, which have coagulation necrosis, and granulocytes, which is 1 to 5 days, and then there is organized thrombus. These three thrombi need to be completely treated differently. We also have types of thrombus. We had Nishit showing us white thrombus here, red thrombus here. This is very highly reflective. And then there is a group which we are not clear what this is, but there is a recanalized thrombus, which is an organized thrombus. This is a group which we still are a little unsure how we treat. We also have various scores of thrombuses which are shown, but clearly what is important to say, there are large thrombuses and small thrombuses, and the large thrombuses are the difficult problem. So the large thrombosis you can treat either mechanically by aspiration thrombectomy or mechanical thrombectomy, filters, thrombus capturing stents like M-guard, and pharmacotherapy with thrombolysis, 2B3A receptor blocker, low molecular weight heparin, and intracoronary. You can give many of these through either the guiding catheter or clearway catheters, or sometimes we can use balloons. But unfortunately, most of these are inadequate in large thrombus burdens. Now, let us see some simple examples of small thrombus. These are very, very small thrombus, and these are very easy to treat. There are many of these patients come in acute myocardial infarction. But there is another group with a very large thrombus, which is there in many of the patients. This is a typical large thrombus patients, which are very different in its own mechanics. The small thrombus, we don't have any problems. We directly stent them very quickly, and there is no problem. There is no issues of no reflow. There are no problems in these patients at all. But you go to the big thrombus patients, and this is a typical patient who has a large amount of thrombus. You can see your thrombus lying all over the artery, and these are the patients which can give you a lot of problems. And if you have a large thrombus, for example, this patient, and you do a direct stenting, this is what you land up with: complete no reflow with problems distally. Another patient with a large thrombus, we just balloon the patient and see what happens. It's a CPR on the table. So we have to be very, very careful that these patients are treated properly. So I would divide this quickly into 5 minutes of non-ST MI, and I divide these non-ST MI and STEMI into two groups. And in each of these, we have a hemodynamically stable patient and an unstable large. So here's the first case: a typical young man with came in with non-ST elevation MI, a troponin which is 0.37, no big ECG change, was treated with dual antiplatelet and enoxaparin, angiogram next morning. And you can see huge thrombus here. And here in this scenario, we have to be very, very careful that you just don't go in and do something drastic like putting a stent. There was no pain, patient was stable. What we started is a 2B3A, dual antiplatelet, and enoxaparin. We just kept the patient on and brought the patient on the next day. And you can see clearly on the 48 hours angiogram that there was an OCT showing a large thrombus here. So given the non-occlusive nature of the thrombus, lack of recurrent residue, PCI was deferred. We didn't stent this patient. We added warfarin. Apart from the dual antiplatelet therapy, the lumens were good. We did not put a stent. So even after 48 hours with a 2B3 receptor blocker, there was enough thrombus. So what we put in this patient was warfarin. A therapeutic INR was achieved, remained asymptomatic. So you have three treatments, so two antiplatelets and warfarin at a low therapeutic INR. And we did an angiogram after 6 weeks. It looks much better now. The things have cleared out. And if you look at this OCT, you can see beautiful clearance of the thrombus. You can just see a very minimum amount of thrombus in the top. But clearly, you could not have achieved even with a stent such sort of a result. So you can be clearly treating these patients medically. Again, this is the thrombus on a 3D OCT. You can see it very picture. There's another patient, again similar patient, 42 years old, peak troponin is 3. Again, a stable patient, angiogram the next day. And you can see again a very nasty thrombus here. So how do you treat this patient? Again, let's not be trigger happy and put in something. Here's the OCT, large thrombus, but non-occlusive. Lumen area is pretty good. So again, don't be trigger happy. Just wait. Use warfarin along with dual antiplatelet therapy, therapeutic INR, brought back at 6 weeks to check. And you can see that follow-up angiography, some sort of ectasia, but again, good flows in the arteries. And you can see the OCT again, very, very dramatic clearance of the on medical therapy with a minimal organized thrombus at the periphery. So again, looking good. Now here are two patients I want to show you, which could sometimes confuse us. One is a 36-year-old male who 2 weeks ago announced STEMI and comes to the cath lab with a troponin at 0.76 with an angiogram. I'll show it to you. And another patient who has non-ST elevation a few days ago, 1.47 is his troponin. And we can see on these angiograms what it looked like. So this is the patient of the first patient, non-ST elevation. And you can see this sort of nasty, dirty vessel. And this is another patient who has again a little thrombotic lesion. You look at the OCTs, and you can see here there is thrombus. This is not very organized. This is the midway thrombus, not fully organized. And you can see in this patient, which is a typical lotus stem experience, which is of a typical organized thrombus, which is very, very clearly organized. The left one is more disorganized and more acute or subacute, and the right one is more sort of the. So here is a case 3, which is more subacute sort of thrombus, and here is the acute top of thrombus in this patient. So here what we do in this patient, in the subacute sort of patient, we put them on oral anticoagulation and see what happens. The artery completely clears out. You're left with a very, very discrete sort of lesion. And again on the OCT, you can see everything clearing out, and there is a stenosis now. All we do is that this is the pictures, the static pictures, again showing now, we just now, after this whole thing, put a short stent and sort the problem out. So here you wait, anticoagulate, clear the vessel, and then stent. While in the next patient is the case 4, which is fully organized thrombus. We don't do anything. We just go straight in, cross, stent. Because here, this is not, anticoagulation is not going to help. This is a typical lotus stem lesion. So you just fix it, and you can see that the stent is really nice, and we have to clear the whole issue. So in short, in a large thrombus with non-ST elevation, who's hemostat stable, keep off your trigger, use 2B blockers, use dual antiplatelet, after which, after 48 hours, you still see large thrombus, give warfarin, bring them back after 6 weeks, complete thrombus resolution is provided, and then you focally stent and avoid all the problems of no reflow because of stability. Now, here we may in a STEMI, we may have more acute problems where you have more pain. I think he's a 26-year-old male presenting with a STEMI anterior wall MI. The patient is front-loaded with antiplatelets, dual, and taken for the primary PCI. That's the ST up on anterior leads. And you can see again a similar scenario, large thrombus here, reasonable flow. So what do? You give intracoronary reticulase, 3 bolus of 4.5 very, very gradually, and wait. The most important thing is to wait in these patients. These are all typical young patients, less than 40 years of age, which is about 20% of our patients. If you read a JAMA paper, it was 24% had less than 45 years of age. So this is post-lysis. You just waited and you cleared the vessels and everything looks clean now. So patient became pain-free. There's absolutely no need to stent these patients. STs come down, everything is clean. An angiogram done 72 hours later looks pretty good in terms of the flows, in terms of the lesion. And it sort of, you do an OCT and you can see some thrombus here, but more of it is cleared. Lumens are pretty good. You don't need to put a stent. Here's another patient, anterior wall MI, young, again 90 minutes window, coming with ST elevation. And you can see here that it is the proximal part is the culprit, but the lesion has the clot has distally embolized. So there's proximal culprit and distal embolization. So what we do now is we use a technique where we puncture the balloon and give reticulase distally and proximally with a puncture balloon. We don't have a KLA. So it's a custom-made balloon infusion catheter, which we inject reticulase now into the coronaries. And what you can see is post-lysis, the flow is little better, but you can see some sort of still thrombus here. But you just bring the patient back after 24 hours, and you can see that the flows are much better, the distal vessel looks much cleaner, and there is no big problem. So we just keep the patients on warfarin and clopidogrel, bring them back at 6 weeks. Same story like non-STEMI elevation, non-ST elevation MI. The clot is all cleared out. There's very minimal thrombus left, and patients do well. Now here's a occluded vessel. Now here's the danger. We would think that we just balloon these patients and stent them, and there is where the problem starts sometimes with no reflow, and you lose myocardium here. What we do is thrombus aspirate, then we give intracoronary lysis and see what happens here. And you can see that things look much better. The flows are much better. The lumen is pretty good. So we just follow it up with 2B3 receptor blocker after intracoronary lysis. Still no reflow at angiogram after 24 hours. And in this patient, if you had stented it immediately, the artery would have completely closed. We give them again a combination of antiplatelets with warfarin, and we do an OCT after 6 weeks. And this is the angiogram at 6 weeks. Again, you can see good lumen. And again, you can see that the vessel is pretty sort of cleaned up. There's some organized thrombus, but very, very minimal. But overall, the lumens are great. There's no big problem here. And you have left all these patients without a stent. Again, another patient, obese, typical young patients who are less than 45. We use thrombus aspiration. Again, angiogram after 24 hours on medical therapy. And you can see again, good flows. Bring them back at 6 weeks. And this is a typical thing which has never been reported. We have all this data now submitted for JAC for presentation on young MI and how with 2-center data with 72 patients. And you can see we have avoided stents in most of these patients and cleared up them with anticoagulation and antiplatelet therapy. So I'm going to go very quickly now. There are multiple patients of similar forms, and we just do the same thing. We just do cleaning up of the vessel with thrombus aspiration after an OCT, and then give them dual antiplatelet, bring them back at 48 hours. If still large thrombus, we give them anticoagulation. And these are some dangerous patients, late presentation patients who create a lot of problems on the table, who are not lysed, come to our table, and you can see that again a vessel with thrombus. We just put them on dual antiplatelet therapy and statins, and we clear the vessel out. So there are multiple cases like this we have, which I want to show you. But what we clearly do is, whether it's non-ST elevation MI or late STEMI patients, what we try to do is not stent. We thrombus aspirate, give dual antiplatelet therapy, bring them back next day. If there's a large thrombus, then we give them warfarin, and now we have started using NOACs. And most of them...
Sorry to interrupt you, sir.
Yeah, this is the last talk.
Okay, sir.
This is my last slide. So we have 34 patients now with this sort of experience, with no stent. And we can see clearly that all that they require is cleaning up of the vessel with either thromboaspiration, intracoronary lysis. And we now have oral anticoagulation and rivaroxaban used in many of the patients with excellent follow-up results and clean OCTs at 6 weeks. And now we have follow-ups up to 6 months with these patients. So I think large thrombus burden is a nightmare. It's in young male smokers with large ectatic vessels. Pharmacological therapy is better, and we should not stent these patients. And use the OCT to guide your therapy and decide what sort of treatment to do. Thank you very much.
Thank you, Dr. Ajit. Great talk. There have been lots of good questions, but I don't think we have time to address them right now. So we will carry on to the next talk by Dr. Sanjeeb Roy. Hopefully, we'll come back to many of these questions in the end after the last talk. Dr. Sanjeeb Roy, please carry on. Dr. Sanjeeb Roy, I think you're muted. Need to unmute. Okay.
Yeah. Good evening, everybody. So I'm going to discuss about the basic FFR and benefit in bifurcation lesion. So what is the problem in, coronary bifurcation lesion? It's a little bit tricky anatomy and physiology. The peculiarities are the amount of myocardium supplied by the side branch is very variable. The pattern of luminal narrowing is complex and differs between main and side branches. And the side branch ostia, if you look at here, side branch ostia usually negatively remodeled, and often there might be an eccentric plaque. The coronary flow through the main vessel and side branches changes dynamically during the intervention. And the narrowing of the jailed side branch could be because of various reasons, which I'll discuss. Now, if you physiologically assess any coronary stenosis, so we can do that in a hyperemic phase and non-hyperemic phase. FFR is a ratio of PD and PA in a hyperemic state, and I'm going to focus on that today. So why do we need an FFR for bifurcation? I've already discussed the unique anatomic features. You have a variable myocardial supply, plaque distribution, and flow dynamics. The problem is there are limitations of anatomical evaluation of bifurcation. In angiography, there might be a vessel overlap, angulation, foreshortening, and after the stenting, the strut artifacts across the side branch may occlude your visualization. And both visual and QC assessments have been variable. While if you look at the imaging by IVUS and OCT, the optimal criteria correlating with functional signification is not defined. And post-stenting, sometimes the jailed side branch may be difficult to access. So FFR guided PCI, an application if we look at, in general, all of us know the FFR has found to improve the clinical outcomes over medical management, or an angiography guided intervention in patients with coronary heart disease, be it the FAME trial, the FAME2 or DEFER. And it has been demonstrated to be safe and effective. Applying the same principles to the bifurcation, it is presumed to give you better results, but it requires a comprehensive understanding of its role and the potential pitfalls. PCI for bifurcation lesion is itself a poor predictor of periprocedural and myocardial infarction, and further stenting may result in a stent thrombosis. So clinical benefits of FFR in bifurcation therefore arise out of reduction in unnecessarily stenting bifurcation lesion when it is not required. However, the application of FFR in bifurcation needs a better understanding and level of experience because there are challenges. So we can divide the assessment into a non-left main and left main. And non-left main, it is initial lesion assessment, evaluation after main branch stenting, evaluation after side branch intervention, if any, and final assessment. In same lines, we also go for the left main, but there are challenges with that as well. So let's look at the non-left main. And this has been very well documented, the benefits in the 12th consensus statement of EBC, that is European Bifurcation Club. And here they recommend that in stable angina, with no objective evidence of ischemia, FFR can be used in either the main branch and or the side branch to determine whether PCI is indicated. But it is not recommended to determine the strategy, that is, you are going for a 1 stent or 2 stent strategy. Side branch FFR, it can be done before main branch stenting, but if it is more than 0.8, it does not exclude the subsequent need for treating the side branch. After the main branch stenting, if it is more than 0.8, despite angiographic narrowing, it indicates that further side branch treatment can be safely deferred. But when FFR is abnormal with pinching of the ostia in angiography, it sometimes may be very difficult because such pinching could be a temporary phenomenon because of vessel wall edema, intramural hematoma, or it can be because of the plaque shift prone for remodeling or carina shift. The management in such complex cases is controversial, but usual strategy is ostial side branch dilatation and careful pot. And if results are still suboptimal or abnormal values persist, we can go for an additional stenting. So let me take you one by one to these steps. So pre-PCI, it is useful to assess the functional significance of main branch. And if you have a 001 kind of side branch lesion, then also it is useful for assessment of side branch. But it is not generally recommended if you have a very small side branch and to assess the significance of side branch when there is a significant lesion in the main branch. If you have a jailed side branch and isolated stenosis of the side branch ostia, again, FFR is not useful. So this is the one case where you can look at here, the side branch looks angiographically very stenosed. However, the FFR is only 0.85, so it can be deferred. So again, while interpreting, we need to be very careful. We need to understand the physiology, that the blood flow in the side branch is less than the main branch, and presence of a critical stenosis in one branch can divert the blood flow into the other branch, which we call it a branch still phenomenon. So any additional reason, either upstream or downstream, will influence the FFR reading, and hence we need to be very careful in interpreting such results to understand the cause of low FFR in side branch. So these are like effects in the upstream or downstream. So this is one case where you have a upstream lesion in the bifurcation. The values were 0.78. And it's very necessary in those cases that you do a pullback. And if you have a significant pullback, you need to consider perhaps that could be a significant lesion. And the one with more pressure drop needs to be dealt first and FFR repeated. And again, in these cases, it's very important in the pullback that you have the drift been taken care of. This is another case where you can find here there is a side branch lesion. It appeared to be a 001 in the angiographic. But if you look at here, the FFR was 0.73. And again, when the side branch, there was some lesion in the left main, which was I-versed imaged. And because it looked like very critical, it was fixed. And once it was fixed again, yet the side branch lesion appeared to be 0.76, but this was 001 Medina, so it was left on medical management. So once you have stented the main branch, again FFR is useful to assess the functional significance of jailed branch, because if it is narrowed, it has implication in the outcomes. It is again not recommended when you have a small side branch, or if you have a diffuse angulated calcified side branch, or if the flow is less. So there needs to be a balance between risk and benefit of measuring the side branch in a jailed side branch. FFR is most effective in such situation when it is measured in a side branch which is large and which has a short ostial lesion. So several factors need to be considered while assessing the FFR of the side branch. And this could be the degree of stenosis, the vessel length and morphology, the vessel size, upstream and downstream region, and the size of myocardial bed supplied by. And one of the most common causes, apart from the stent struts or dissection, spasm, and thrombus, are the plaque shift phenomena and carina shift. And this might angiographically look significant, but most often the FFR is negative. And if it is significant, again, it can be dealt with a plain balloon pot side branch and pot approach. These are a couple of studies which have shown the angiographic and functional severity on the side branch, and there is a negative correlation mostly with the side branch stenosis and FFR, as you can see in this slide. Despite a visual assessment of a significant stenosis, the FFR is negative in most of the cases. So this is another example where you can find the baseline angiographic showing significant disease. The main branch was stented, and if you can look at here, the side branch looked significant, but the FFR was 0.93. So again, it can be left in medical management. So after, if it is significant, we do a side branch intervention, like in most of the cases, a ballooning, and we can again assess the side branch to assess the procedural success. And it also predicts the outcomes of kissing balloon dilatation. Again, it is not recommended if you have a slow flow in the side branch or severe dissection. So immediate post-intervention side branch FFR is a very useful index to predict the functional outcomes of jailed side branches during the follow-up. However, one must remember the functional and angiographic late loss is dependent on the degree of injury from the intervention. So these are two studies. One is by Koo in 2008, and another is the Nordic Baltic bifurcation 3 study. And again, if you look at here, there were no changes in the side branch during the 8 months follow-up with kissing balloon dilatation. However, in the Koo group, the binary restenosis rate was 48%, and with those who had an FFR of 0.75, it was only 8%. So what was found by the Koo group is the kissing balloon dilatation routinely does not make any impact. Again, FFR versus angio-guided, we have DK-CRUSH-6 and the Koo studies. It showed that treatment of side branch was less with FFR-guided group than in the angiographic directed group. The MACE and DK-CRUSH study at 1 year was comparable, but restenosis in distal branch was surprisingly more frequent in the angiographic group than in the FFR group. And lastly, once you have done the side branch stenting, you need to look at the residual ischemia in the side branch, and it is not recommended overall to look at the complex outcomes of two-stage stenting. So high side branch FFR does not always guarantee a procedural success, but mostly has a favorable clinical outcome. So this is another subset. This is entirely different. This is called the left main. Again, left main bifurcation has a different implications because it carries the highest amount of blood, supplies a large myocardial mass, and both the branches, the LAD and circumflex, are as important. So we need to assess the left main. It is very difficult non-invisively. Again, angiographically, sometimes it is very difficult to appreciate. And most patients with left main assessment might have an additional stenosis upstream or downstream. And again, they are often associated with comorbidities. As already discussed, the limitations of angiographic assessment, there are overlaps, there's spill-off contrast, resulting in not proper visualization of the ostia. There is a lot of streaming effect, lack of true normal segment when it is diffusely diseased. Again, there are calcium. So all these factors result in underestimation of the left main stenosis angiographically. So FFR is a very good tool, but we have to remember a couple of things in the left main. If you have an ostial disease and you need to disengage the guide, do the equalization in the aorta. And again, here the IV infusion is much better than given a intermittent bolus. And there are influence of additional lesion on the FFR estimation of left main. Now this is a scenario where only the ostial left main is diseased. So FFR is preferable to assess both branches, and it should be presumed from the angiography that both are disease free. But if you have a downstream lesion, particularly if it is in the proximal and very critical, it might have an effect, the FFR assessment, when you have wired the circumflex.
Sorry to interrupt, sir.
Yeah, 2 slides.
Time to conclude, please.
Yeah, if you have a downstream lesion. In such cases, if it is more than 0.85, it can be deferred. So this is another example where it was 0.87, which was underestimating the left main lesion. Once the LAD lesion was fixed, it was 0.84. But if you have a single unit lesion, IVUS is very important in such cases, and we need to fix them that. So I'll skip the last case where it was a haziness seen in the left main, and we did an FFR. Now here the FFR in the circumflex was 0.81 and the LAD was 0.7, but this had many lesions, and it affected the assessment of FFR. But since it was not more than 0.85, the left main lesion was considered significant, which was fixed up with a stenting, and this were the images. The 5-year outcome of the crossover stenting again had a favorable when you assess the side branch value. So to conclude, angiographic and anatomic parameters of coronary bifurcation lesions has limitations. FFR is very useful tool for evaluation of bifurcations and deciding the strategy, but operators should have an adequate understanding of the coronary bifurcation physiology and possible pitfalls of FFR. EBC recommends it as a part of standard PCI procedure. But very important, the last point, the ischemic burden is more important than presence of ischemia or measured FFR value, and the risk and benefits of complex intervention should be incorporated in the treatment decision after the FFR measurement. Thank you.
Thank you, Sanjeev. That was wonderful. So we come to the last, last lecture of the session, and a close friend, Rajni, he would be talking about the QFR.
Yep.
So that's something new. That's not wire-based, and it's something very new. So and useful actually.